Guys, so today let's start with chapter wound healing. And this chapter is really fantastic because it's a very easy one. So, what is wound healing? Well, wound healing is that just healing of the wound, right? You got a wound and then it heals. Now, how does it happen? Now, the question number one is what is regeneration? So the word regeneration, it means replacement of the damaged tissue with its native tissue. Okay, that's the concept of stem cells. Now, what are stem cells? Stem cells are these cells who will reproduce and they will make clone of the particular cell, right? And they'll make clone and they will make sure that their population is exactly the same as it was before starting this process. Okay, that is stem cells, right? If the population of stem cells go down after the whole process stops, right, it means they are not stem cells. Okay, stem cells, they survive, they stay forever, and they keep producing clones. Okay, that's the concept of stem cells. So regeneration will be there if there is any sort of replacement of the damaged tissue with native tissue. That is replacement. That is regeneration. Okay, what is repair? So repair is the replacement of the damaged tissue with fibrous scar. It occurs when the tissue lacks regenerative capacity or regenerative stem cells are lost, right? So imagine this is this is a tissue, all right, and you provide damage here just on the superficial layer, and on the basement membrane you have stem cells right here sitting. So imagine if you provide damage here, if you provide damage to the stem cells, then they will not be able to make clones of these scars, right? And you will have something called as a scar, a really big scar, because you have cut so deep into the skin that you have damaged these stem cells. So that's the concept of having a scar. If you have a scar, it means you have damaged the stem cells. The stem cells could not make clones, and now you have a scar. So that's the concept of stem cells. So this is called repair. When the damaged tissue is replaced by a fibrous scar. What are the three types of tissue based on regeneration capacity? Three types of tissue, okay? Three types of tissue. Okay, so there are three types. First is labile, second is stable, and third is permanent. Let's see permanent first. Permanent tissue is that a tissue which cannot regenerate. It means which has no stem cells, okay? So if they do not have stem cells, it means 100% they will have some sort of fibrous cap or fibrous scar on them. Okay, so myocardium, skeletal muscles, and neurons. So once they are messed up, you will not have any sort of stem cell regeneration because they lack stem cells. Cool. Other thing is called labile. Now the cool thing is that labile, what is labile? Labile is something that can be changed easily. Okay, so how can it be changed? It can be changed because they have stem cells, right? So labile cells, labile tissue, they are continuously regenerating. They are found in intestine, stem cells in the mucosa crypt. They are found on skin. Stem cells are on the basal layer, most bottom layer of the epidermis, bone marrow. Because bone marrow, we need continuous production of these hemopoietic system, right? So hemopoietic system stem cells, IEL, you can't identify HSC by microscope. The presence of CD34 molecule tells it's HSC. Okay, so what I'm trying to say here that what are these CD34 cells? First of all, these CD34 cells are just glycoproteins, right? They are just glycoprotein markers that are found on these hemopoietic stem cells, right? And they help these cells to stick on the bone marrow and respond to the growth factor, right? So when we say CD34 positive cells, we mean that we are talking about stem and progenitor cells that are capable of regenerating all the blood lineage, okay, all the blood hemopoietic system, okay. So what does the presence of CD34 means in the bone marrow? It just means that the bone marrow has active hemopoietic stem cell regulation going on. That's it. Okay. Now, other question rises here is that we can't see it microscopically. Well, we can't see it microscopically because you can't identify them usually. Okay. Because when we look at the bone marrow smear, okay, or under a biopsy, right, like under a microscope, these CD34 these cells, right, they look very small cells. They are like very small blast lymphocytes. So they look very similar to the lymphocytes, okay? So they are morphologically very indistinct. So that's the concept. And there is no special structure that they have, these CD34 cells, right? So we can't really say that, oh, these are these, right? So that's why we need immunologic or this molecule markers, that is CD34 positive. Okay. And again, we can just, we can just do immunohistochemistry, IHC, and it stains the tissue with anti-CD34 antibodies, right? And then we can like say, oh, okay, it says CD34 is positive. That's how it happens, okay? Okay, so lungs have stem cells. These are type 2 pneumocytes. Most of the lung is covered by type 2 pneumocytes because we need them, because we have injuries happening again and again. Type 1 pneumocytes we have, and type 2 pneumocytes we have. Just know that. Okay, circles are the crypts of bowel, okay? The crypts of bowel, these are crypts of Langer, something like that. I don't remember the name, but usually what happened, here's the concept, is that this crypt, right, of the bowel, this crypt of the intestine, the stem cells are right here on the middle. So that, imagine there's the surface cell, right? There's the stem cells, then we have parietal cells, then we have some cells other, then we have blah, 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 right? Then in the middle, we have stem cell. In the middle, we have stem cells so that it can go down and it can go up. That's why we have stem cells in the middle, in the crypt of the bowel. That's the concept right there. Stable cells. So labile cells is that we can replace them easily. Stable cells is that they don't continuously regenerate but have the ability to regenerate if needed. So liver, right? Compensatory hyperplasia. You remove half of the liver, half of will it grow, right? Half of the liver will grow again. Proximal tubule of the kidney. Proximal tubule. Proximal. What is it proximal to? It is proximal to Bowman capsule. Okay, that's the Bowman capsule. That's the imagine that's the Bowman capsule, and this is the tubule, right, proximal to the Bowman capsule. That's why it's named proximal Bowman tubule. So proximal tubule of kidney. The patient on acute tubular necrosis. So necrosis is happening, death of the tubule is happening, and they are put on dialysis until their PCT regenerates. So they are amazing. They can regenerate on stimulus. So they are stable. Okay. Let's talk about granulation tissue. What is it? Why we need it? Blah, blah, blah. Okay. So what is granulation tissue? And the granulation tissue is different from granuloma, which is a very different thing. So granuloma is that when the macrophage, they convert into epihistiocytes, right? I hope we can, cover that again. Wait. So what happens here is that the activation of CD4 positive cells, right, via CD28 and B7 second signal happens, right? And these get activated. Once they get activated, they make Th1 and Th2. Th1 makes interferon, this gamma, and they further make macrophages. Now, upon a good stimulus after CD4 again to the macrophage, they will go again via MCH2 molecules, right? These are the presenting molecules, and they will go to CD4 helper cells, right? And now this CD4 helper cells will right away go to interferon this gamma, and this will turn into, not into macrophage, but a granulomatous inflammation. And this granulomatous inflammation can be caseous, cheesy, or non-cheesy. That is non-caseous. So that's the concept of granulomatous. So that is a granuloma. Okay. And the typical, the practical definition of granuloma is that these are epihistiocytes, right? Macrophagic epihistiocytes. So that's the definition, right? So macrophage epihistiocytes, right? But this is different. Granuloma is different than granulation tissue. Let's see, what is granulation tissue? So granulation tissue, what are the three important cell types in it? Okay, so let's see what is granulation tissue. Again, it is present in the early phase of repair. Okay, so we have early phase, and it contains early form of scar, right? Later, this collagen turns into collagen from type 3 to type 1. Okay, so granulation tissue is just that when we have collagen type 3 and that turns to type 1. Okay, so that's the holy grail of this concept. So it presents in early phase of the repair. It contains fibroblast, capillaries, and myofibroblast. So fibroblast, we need fibroblast because that's the type 3 collagen, right? It turns into type 1 later. Capillaries, of course, we need for nutrition, and myofibroblasts, they contract the wound. Okay, now now the now one cool question arises. Really, it's a cool question. So we have three phases, right? We have early phase, right? There's the inflammatory phase. Then we have proliferative phase, and then we have remodeling phase in the healing context. Okay, so we have three phases. Inflammatory, we understand homeostasis has happened, inflammation is happening, right? Primary homeostasis has happened, secondary homeostasis, the cap has been formed, right? Now we are in the proliferative granulation, okay, phase. Now in this granulation, it will be followed by angiogenesis, right? The formation of blood vessels. And then we have something called as fibroblast activities. And then in the end, we will have epithelializations, right? The epithelial layer will be formed over this whole thing, right? And then in the end, we will have remodeling phase. That's the collagen turning into type 1 from type 3. So why do we have myofibroblast in this proliferative stage of granulation, right? We have this myofibroblast because they are these specialized fibroblasts that they can mimic, they can acquire smooth muscle like properties. Okay, they can almost mimic smooth, not mimic, they can acquire smooth muscle, acquire, right? So they can acquire this smooth muscle, right, properties. Now why do we even need smooth muscle in the first place here? Because they express something called as alpha smooth actin, right? These myofibroblasts. Now these myofibroblasts, they are just like contractile fibroblasts. Okay, they make sure that the tissue which is healing, which is going into proliferative stage, it's held together. It's not going out, it's not just breaking apart. Okay, now why do we even need this contraction? Just I want you to imagine a wound. Okay, for example, this is a wound. Now this is an open area, right? Now before epithelialization, before the connective tissues are fully formed, the body need to reduce this gap, right? We need to reduce this gap between the edges of these wounds. Yes, so to reduce this, we have to minimize the exposed area, we have to reduce the blood loss, right, the fluid loss. We have to reduce this so that less infection is going to happen, right? We have to reduce it. So that's where the myofibroblasts come into picture. Okay, now exactly how they do is that these are just tiny muscle fibers, okay, fibrofibers, and they tug with each other, and they just tug the wound together from both sides like this, like they tug it together. And it's one of the earlier phase because still the wound is still open, right? So that's why we need to close the wound. So that's the idea here. Okay, what happens when the granulation tissue is replaced by the scar? And the cofactor is, what cofactor is needed? Cool question. So collagenase. Collagenase means, ase means removal. So collagenase removes type 3 collagen and replaces it with type 1, and it needs zinc as a cofactor, right? Now another question arises, why do we even need zinc? Before answering this question, I want to answer you, what is collagenase? Collagenase is this enzyme that breaks down this collagen, right? From type 3 it converts into type 1. So this collagenase, it belongs to something called as matrix metalloproteinases, MMPs, right? And these enzymes, they can convert, they are the part of these extracellular matrix part. Okay, I'm giving you a lot of big terms. Okay, let me just answer you simply. The key here is that these MMPs, right, these family of collagenase, they convert, right? And why do we need zinc? Is that zinc sits on these collagenases, okay? And it performs two things. It works as a catalyst of water here, because without zinc the enzyme cannot activate water, okay, and it cannot hydrolyze the collagen peptide bond. Okay, zinc binds with this water, right? It binds with the water and it polarizes, right? And it makes sure that it's really reactive. Now that water molecule attacks the peptide bond in the type 3 collagen and cleaves it into a type 1. Okay, so that's why zinc is needed for, catalytic way, in a catalytic way. Other thing is that zinc gives a really cool stabilizations. Just imagine that zinc is like a 3D conformation. Zinc really helps into stabilization because it helps to maintain this structure, right? That's the concept behind zinc. Okay, it makes sure that the remodeling from type 3 and type 3 into type 1 is happening. Okay, that's the concept. Okay, other question. Okay, so what are the type of collagens? What are the 4 types of collagen? We have type 1, that is bone 1, found in bone, bone 1. Type 2 is 2, cartilage 2. Type 3 cartilage is granulation tissue, embryonic tissue, very pliable, moldable, right? Because that's why they are used in early phases of repair. And then we have type 4, that's the basement membrane, right? So we need to convert this from type 3 to type 4 with the help of collagenase, right? That's why I wrote collagenase here. Okay, how do regeneration and repair happen? What are the key molecules here? So let's see, they occur by paracrine, means neither they are endocrine nor they are exocrine, so they are paracrine, in the middle or around, right? Secondly, we have growth factors, right? Some of them are, so these are like growth factors, really important to remember them. So fibroblast growth factor powerfully induces angiogenesis, fibroblast, right, and skeleton development. Okay, what is VEGF, vascular endothelial growth factor? These are angiogenesis. So two growth factors for angiogenesis, right? FGF and VEGF. PDGF, now this is growth factor of endothelium, smooth muscle, and fibroblast. Tumor growth factor alpha and beta. Alpha goes for epithelium and fibroblast, and beta inhibits the inflammation. As you can know, this Th2 molecules, which comes from T helpers 4, they can produce, this TGF, beta, and IL-10. Let me just go and revise that right there. So Th2 makes IL-10, that is anti-inflammatory, right? And we have something called as beta. This tumor yes, tumor growth factor beta. So alpha promotes health, promotes this epithelial formation, and beta inhibits the inflammation. So that's also very very important, because imagine you have this inflammation going on again and again and again. So again, the remodeling, the healing will be stopped. Okay, so that's very important. Contrast the wound healing by primary and secondary intention. Okay, so what is primary intention? Primary intention is that when the wound edges are brought together and there is minimum scar formation. Okay, I told you that is done by a myofibroblast. Okay, secondary intention is that when edges are far away and the granulation tissue fills the gap, due to presence of myofibroblast would shrink quite a lot. Okay, due to presence of myofibroblast would shrink quite a lot. Okay, so okay, this is one wound and this is one wound. Which is a bigger wound? This is a way bigger wound, right? And this is a smaller wound. Now this smaller wound is that this is primary intention happening right there. The edges, they come closer to each other, minimum mere very less scar formation. Here the myofibroblasts, they come and they join the wound together, right? So this is secondary intention, and that one was the primary intention. Explain the formation of the structure of collagen. So collagen is formed by multiple alpha strands inside the cells. All right, these multiple alpha strands intertwine to make procollagen, and then they come outside the cell. So we have alpha cells, right? Alpha cells, and they intertwine with each other like that. Okay, and then once they intertwine, they make something called as procollagen. Okay, and now this procollagen, it comes out of the cell, right? Now it is pro and it's active. Okay, so the structure of alpha strand is GLYXY, and where X and Y are the proline and lysine. All right. In the extracellular space outside the cell, there are multiple procollagen are clustering via hydroxyl groups in proline and lysine to make collagen. Okay. So vitamin C is needed to hydrolyze these proline and lysine, and cross-linking is done by copper as a cofactor. So in formation of collagen, we need copper. Okay. And in formation of this zinc, so zinc is needed as a cofactor for this shit to happen. The transformation of type 3 into type 1. Zinc is needed here. But for the formation of collagen, for the formation of cross-linking of what? The cross-linking of these proline and this, these alpha collagen, we need copper. Okay. What are the most common causes of delayed wound healing? I mean, delayed means there's something which is leading to, delayed means, I mean, infection, most common cause, because body is spending their resources on fighting the infection, not, healing the wound. Vitamin C, I told you, vitamin C is needed to hydrolyze proline and lysine, right? I mean, these are just cross-linking of these things needed, right? Cross-linking of proline and lysine needed. So if you don't have vitamin C, you will not do cross-linking, and once cross-linking is not done, you will not, Copper deficiency, copper is cofactor, right? Zinc deficiency, again, type 3 collagen can't be converted into type 1 by collagenases because zinc is a cofactor of this shit. Foreign body, ischemia, diabetes, and malnutrition. They are diabetes is one of the very problematic disease. What is the wound dehiscence? So, wound dehiscence means rupture of the wound, commonly seen after abdominal surgery. Okay. What is hypertrophic scar? Hypertrophic. This is a hypertrophic scar. Hypertrophy is happening here. The scar tissue being big but localized to wound caused by excessive type 1. Okay. Now, that's another one cool question here. Now, the cool question here is that how exactly this hypertrophic scar formation happens. Now, let's try to understand this, right? To understand this, we must try to recap the main stages of wound healing or healing recap, right? So first we have inflammation, then we have proliferation of the fibroblast, right? And then if the wound is really big, we have secondary intention, that is the myofibroblast laying down the type 3 collagen, and then we have collagenase converting these type 3 into type 1, and then we have remodeling, right? The maturation, type 3 replaced by type 1, right? And this is done under collagenases and TGF beta for the stopping of inflammation, right? So that's the normal thing going on, right there. Now, what goes wrong in this hypertrophic scar is that the fibroblast, right? The fibroblast, they become hyperactive, okay? And they produce a lot of type 1. And this myofibroblast, they stay there, they persist longer, and they keep contracting, and they keep making sure that the remodeling is happening again and again, right? And then these collagenases activity is reduced, or maybe the whole activity is stopped, is inhibited, so they can't. So again, the collagenase is stopped, so they can't degrade the excess collagen properly, right? So this imbalance happens. Now, this imbalance between this collagen synthesis and collagen degradation happening, right? Now, this condition is actually not excess it's not excess collagenase, but rather insufficiency of collagenase activity, right? And this type 1 collagen accumulates because the breakdown is not happening due to less activity of collagenase. Okay, there's insufficiency of collagenase. That's the holy concept. That's the main concept. So let me write this. Insufficient collagenase activity leads to accumulation of type 1, collagen. Okay. Now, why the type 1, dominates? Why? This is a cool question to think about. Why can't type 3 or type 5? I mean, type 5 doesn't exist. So why 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 it's dominating? It's dominating because of some points. Okay, one of the point is that this happens in early wound, right? So in early wound, mostly type 3 is loose and thin, right? And in normal healing, collagenase gradually replace type 3 into type 1. Now in this hypertrophic scars, the fibroblasts are overproducing the type 1, right? And these fibers are really thick and dense, right? So they cannot, cross link very properly. Okay, so this makes the scar really raised and really stiff and hyperemic, really. And so cool shit here that the whole this structure is confined within the boundaries of original wound, unlike something called as keloid. Keloid, actually, on the other way, it spreads out of the boundaries of the wound. Okay, so describe keloid: scar tissue way out of the proportion of the wound, caused by excess secretion, excess type 3 collagen, more common in African Americans, and classically affects earlobes, face, upper extremities, right? So cool thing, right? That's a keloid if it goes out of control. But hypertrophic scar is this, that boundaries are there intact, and we have a lot of type 1 collagenase activity here, right there. Okay, now another question you can ask me is that why there's insufficient activities of collagenase here. uh well, there can be a lot of things. For example, we can have something called as tissue inhibitors of these collagenase, right? They can really stop these collagenase. Or we can have something called as persistent infection that can lead to persistent inflammation, and that can lead to tumor growth factor beta 1 really being active, and then it keeps these fibroblast active. Or we can have this zinc deficiency, right? Or we can have some sort of low oxygen situation. So all of these reasons will affect insufficiency. They will like result into insufficiency in collagenases, right? So that was the whole concept about this wound healing. Okay, regeneration due to stem cells. If we have stem cells, we call it permanent. Stable is that we can change it upon stimulus, and labile is that 100% they're gonna get change. And CD4 positive, it means they are just doing the HSC, that is hemopoietic stem cells, right? They are doing that thing. So that was the whole chapter on wound healing, right? That was the whole chapter of inflammation. It's a very cool and very easy, I think, chapter once we really understand the concept behind it.